when we talked about the prospect of being able to do something, disease-modifying therapy for MS, people waved their hands, talked about what they could do, what their anecdotal experience was. And while experience matters a lot, it's been just shock and awe to see over the last 2 decades the evolution of evidence-based medicine. Even though you know and I know, when you show something in 2 different groups and you show A versus B and A works and the biostatistician does the analysis, you know about this, Audrey. They do the analysis, they show a big effect, but size only matters if it's significant, if there's a big p-value. You want to see a big effect, if you want to see a p-value of 10 to the minus 3, 10 to the minus 4. You know what we call that? Big size and a p-value. That's called the biostatistician's wet dream. That's what they live for. I don't know if that's what you live for, but that's what they do. So it's very important that we underscore the importance of evidence-based medicine. But at the end of the day, all of us know we try things because we don't have a randomized controlled trial for every question therapeutically operationalized in the clinic. You know that, I know that. We're trying things all the time. And I think you heard beautifully Erica Simpson's talk about the things she has learned in her experience in taking care of myasthenia and other challenging patients. And who among us has not had similar pearls and pitfalls when we've run out of the evidence-based studies and what doesn't apply to a patient? We try something that works. Is it true? Is it just that individual patient? But individuals matter. They matter a lot. In fact, my friend Rich Dewey's in the back, and we call that what, Rich? We call that an art form, right? You can't do stats on 0 or 1. But when you're sitting in front of that one patient, they all want to know the same thing. What would you do if I were your wife? Sometimes it's a big giant guy, like who works for American Airlines, puts hearts on the plane, and he almost says that thing, and then everybody gets a little upset. But you have to be very clear. It's germane to talk about this. I worked with my wife for the last 27 years. She's the center of my universe. By the way, Will, you may ask about this. Will, Bradley, I love you. It's like, you're here at the show again. It's great to see you. But nothing's changed since the last time I saw you. I'm still madly in love with her. And the reason why I bring that up is you might do different things to different wives, depending on how you feel about that. Is that right? Absolutely. Okay. So let's start at the beginning. Practical immunology. Stan, I know you wanted some of this, so we got to talk a little bit about this. Where do we begin? It doesn't mean that everything therapeutically in MS is driven by immunology, but one thing we have learned over the years, it plays a very central role. It's not everything, but it's clearly important. So let's talk a little bit for a minute about innate and adaptive immunity. And it's particularly timely, Stan, because one of the most recent Nobel Prizes that were awarded was awarded to Bruce Beutler, who was at UT Southwestern, and did a lot of his seminal work on innate immunity while he was there, before he took off for Scripps Clinic and Research Foundation in La Jolla, and then fortunately we got him back right before the Nobel Prize. So it was a perfect thing for UT Southwestern. They love to talk about the 5 Nobel Prize winners that we have on campus. The innate response, as the word indicates, is the locked and loaded response mechanisms that we have that are not driven by memory or specificity. So it's extraordinarily important to understand that we have these first-line mechanisms before you ever see exposures, virus, bacteria, parasites, fungi. You have the ability to respond even before you've ever seen these particular challenges. And in fact, in MS, this topic is a little bit germane because people talk a lot about today the fact that maybe as we've gone from the third world to the second world to the first world, we've seen a corresponding escalation in what? The development of autoimmune diseases. That we've had some compromise in the ability early in life to develop tolerance mechanisms, which may have something to do with what we have, or perhaps what we're not seeing at the same frequency of things we may have seen in other generations. What I'm talking about is early life exposure to the pathogens is an incredibly important driving force to help develop the discrimination between self and foreign, the so-called hygiene hypothesis. The innate response is locked and loaded, no memory required, and if you see things that trigger innate responses, each exposure is associated with a stereotype response, whereas adaptive immune mechanisms are what? The reciprocal opposite. You see a polyvalent polio vaccine, Your mom takes you for boosters. You get an anamnestic response. Now you've got affinity and avidity maturation, T-cell receptors, immunoglobulin, hypermutations. You make antibodies, and over time, class switching, and now you've got memory. You're locked and loaded, but not the innate system. So what is the adaptive system? We've already set it up. These are specific responses. There's cellular and humoral immunity, and as I'm going to talk about a little bit later, the critical balance between B-cell and T-cell strategies in the immune system is incredibly important. In fact, the application of one of the therapies you're going to learn a lot about, called anti-CD52, or CAMPATH, or alemtuzumab, or the brand name Lentrada, not yet approved, but maybe this year, is a therapy that binds to 52, which is a protein on most of your circulating immune cells, and you delete the immune system and you reboot. The problem is that the B cells come back faster, earlier, 3 to 6 months, which preempt the return of T cells over 12 to 16 months. What's the problem? Well, it's the phenomenon of the mice will play when the cat's away. And as you know, that particular drug, CAMPATH, Lentrada, very exciting, looks incredibly efficacious, robust, like nobody's business, but these patients develop other autoimmune diseases. You may exact remission on their multiple sclerosis, but I'm sure as time goes on, the FDA will require a black box warning for that drug, saying between whatever the number they decide upon, 18 to 30% of people develop autoimmune thyroiditis. Now, I would trade my MS for thyroiditis, but you don't get to choose. Some of those patients may get Goodpasture syndrome, and that's a big problem. Some of those patients may develop ITP and other immune-mediated disorders, so you don't get to choose. So it's important to recognize that in adaptive mechanisms, we have balanced systems between T and B cell immunity. Some of the things that we are doing by manipulating the immune system in MS therapeutics and in other diseases may, in some circumstances, breach or compromise that critical balance. And I'm very excited about CAMPATH, but that's an example of an agent we'll have to learn how to use. So let's talk about sort of a creative strategy. What if you happen to have been a neurologist in Dallas, Texas? I don't know who that person is, the gender. Perhaps you treated maybe 14 people off-label with that drug, and you heard a lot about the development of 18–30% of autoimmune thyroiditis, and you have 14 patients treated off-label who were on fire. And the application of the drug stereotypically led to remission. But now you're waiting, and you're nervous, and you know the B cells are coming earlier than the T cells, and as Erica Simpson underscored beautifully, the application of this other drug called rituximab, by the way, this is all off-label, I didn't tell you who this neurologist is, except this person is in Dallas. I'll give you a little clue. That person has a very large brain-to-body weight ratio, which only works for intelligence up to the point of dolphins, so I'm told. Beyond that, it doesn't matter. And could it be if you gave small doses of rituximab, Dr. Simpson's right, you can't get it paid for, but if you used not a gram, not 375 per square meter, as little as 100 milligrams, that's the smallest vial it comes in, 100 milligrams will suppress CD19. You know, it's a 20 blocker, but 19 comes up earlier and lasts longer, so you want, pray go, so you measure 19. 100 milligrams takes CD19 to 0, but only for a mean of about 100 days. So my colleague in our center, Ben Greenberg, published this beautiful paper in MS last year showing if you have no money, you give 100 milligrams, it's $650 for a 100 milligram vial, and you get it 4 times a year. That's cheaper than the typical injectable disease-modifying therapy for 1 month. So my point is, could there have been these 14 people treated off-label who were given small hits of Rituxan to knock B cells down until we were following the evolution of the T cell repertoire and then left these patients alone? I'll just leave it to your imagination. Everything I just told you is off-label. Rusty Katz is not here, right, from the FDA, but there are things that people do. Let's talk about the instruments of specificity. We now know that not only are there, thank God, hypermutations in the genes that code for T cell receptors, but hypermutations in the immunoglobulin genes that code for antibodies. If you didn't have hypermutations, you wouldn't be able to develop immune responses. You couldn't get immunized. So it's critical to understand that these mutations, these rearrangements are critical, and sometimes you make mistakes. Meaning the rearrangements code for awfully close specificity against self. And the editing mechanism that allows you to, quote, not go there, like in multiple sclerosis, is something our B-cell immunologist Nancy Munson in Dallas would say is called receptor editing. And perhaps that's one of the mechanisms by which two identical twins living in the same house, the same clothes, they really are identical. She would be the first to tell you they're not identical. They were identical. But once the immune cell, antibody, cellular repertoire becomes developed, decisions are being made quite independently in those two identical twins. And it's not just their vitamin D level, who was more stressed out, are they different? They are actually making immunologic decisions that are not being made at the same time in exactly the same way. So could it be that one identical twin fails to receptor edit and goes there and develops oligoclonal bands and slowing of P100 evoked potentials and has classic hyperintensities on MRI and eventually develops attacks, and the co-twin does not? You got to be careful, because we usually say that the incidence or the prevalence rate of MS in North America is 1 in 800, 1 in 1,000. If you have MS, somebody in your family who's not identical, what's the risk? 20 to 40 in 1,000. But if you're identical twins, we say it's 300 in 1,000. But those are old studies. Most of those studies are retrospective, and they were kind of pre or just at the MRI era. First person in the world with MS to be imaged was Ian Young in 1981, and many of those twin studies antedate that or shortly thereafter. My point is, if you really look at identical twins, if I have one, I'm always looking for the co-twin. Because the issue is, maybe they don't develop clinical disease, but do they have a cult imaging disease, what we would call radiologically isolated syndrome, and people are lost to follow-up, aren't they? So many of those studies make conclusions about 25–30% concordance rate, but they're not following those people for the longevity. I would make the argument concordance rate clinically, radiographically, in both is probably better than 50 to 60%. But nevertheless, it's nowhere close to 100%, which suggests that genetics are important, but they clearly are not the entire story. We've learned a lot about the role of the major histocompatibility complex antigens. Why do I put these up here as part of the review? Because you know and I know, Stan, that among the factors that we think about as a risk predilection for MS, where you were born, the latitude, your vitamin D levels, have you been exposed to Epstein-Barr? And now we know what are your antibody titer levels against eVNA of Epstein-Barr virus, and are you a smoker? And what is the D level? And what is your status in terms of the MHC haplotype profile? Meaning, we have genes of susceptibility, but the big one, HLA-DR2 1501b1, that's a mouthful. Say it again, HLA-DR2 1501b1. But you know, I know Woodfin knows this because we've been doing this for years. It's the same gene that he learned 20 years ago. But if you've got one, and now you have two haplotypes, and you have mono, and your eDNA IgG is high, and your vitamin D is low, and you're a smoker, now your risk is not 10-fold higher, 20-fold higher. Remember what I said about identical twins? 20 to 30%. If you have all of those factors together, smoking, low D, eBNA titers are high, and a double haplotype for the HLA-DR2 1501b1, do you know your risk, your relative risk ratio elevation is up to 400-fold higher, suggesting that not only do we know about factors that increase the risk, by the way, a lot of this came from the Harvard School of Public Health study, 183,000 women, we know a lot about that, but I mentioned two factors that are imminently modifiable: smoking and levels of vitamin D. And Dr. Simpson beautifully underscored when you were talking about Foxy not talking about me or your patients, but she was talking about regulatory cells. CD4, CD8, CD25, FOXP3 cells. In myasthenia, which you know, in MS, almost all of the therapies that we have that have benefit, not all, have a variety of effects, but one of them is to increase the circulating clonal frequency of regulatory cells, FOXP3. And you know what's really interesting? When people, before we had a lot of treatments, were in periods of natural remission, the clonal frequency of circulating levels of FOXP3 were up, and for whatever reason, people got stressed out. They were like me, they grew up in California, my parents were the West Coast distributors in Jewish Guild, so now you have an MS patient who's stressed out, and all of a sudden you develop an exacerbation, and the clonal frequency of the FOXP3 regulatory cells go down, and the Th17 cells go up, and other pro-inflammatory circuitry, either cells or the currency systems they make, the cytokines and the chemokines, go up until you transition out of that fugue state immunologically back into remission, and then it reverses. But with disease-modifying therapy, you have the ability to modify that. And guess what? If you bring your vitamin D levels from those low, inadequate levels of 10 to 20 nanograms per mil and bring them up to 60 to 80 nanograms per mil, not only will your risk of breast and prostate and colon cancer go down and your bone and mineral mass will go up, but your clonal frequency of FOXP3 cells go up. And if you get on PubMed today, or right now, you'll see there's not a few observations about this. There are innumerable observations relating to this modifiable factor. So it's become very complicated. We've gone from pro-inflammatory Th1 to Th2. We always knew, Stan, that was an oversimplification. So now we've expanded into 17 cells, and as Erica was talking about, the development of regulatory cells. By the way, that's an oversimplification as well, but it has actually stood the test of time when you look at the yin and yang, in and out of remission and exacerbation states. You actually will see people do this, just like I told you. This is one class of regulatory cells. Here are healthy controls. Here are MS patients in remission. They look indistinguishable just with respect to clonal frequency. But if you look at individuals in the midst of exacerbation, it's not UTOS, it's novel, it's more than 24 hours, there's no fever, and guess what? No enhancing lesions, and in this case, eloquent. So homolateral spinal cord on the right, and I've got a right hip aesthetic hemiparesis. So really definitive ironclad worsening, and you can see that if you sample, not just today, but 6 hours from now, tomorrow, next week, this is not a sampling freak. This is really a representation of the shift in the bias of the immune system. It happens. Now, my time is limited, even though I thought I was going to have 3 hours, which you promised me, but he forgets that particular item. But I want to talk about where we are with therapeutics. How have we gone from those principles of immunology to the principles of disease-modifying therapy? Not all therapies are necessarily going to be immunologically based, but the ones we currently have are heavily immunologically based. I want to reiterate this for you in case you think I was making this up, and you wake up in a cold sweat and say, did he say a 200 to 400-fold increased risk if you have a double haplotype of the gene that has stood the test of time, and that the titer of eBNA, IgG against EBV, and a history of mononucleosis and smokers and low D levels? Yeah, I can give you references for this. That's the number. 200 to 400-fold risk elevation. By the way, only the bottom two thus far are modifiable, although we may wake up in another decade and have early life immunization, just like with polio and measles and mumps and rubella. We may have an effective EBV immunization, which will confer benefit in our population across a number of disorders, not just multiple sclerosis. This is where we are. When I thought I would do this in 1979, I was at UC San Diego, and my advisor at the time had just come from the United Kingdom, Francis Crick. He says, okay, I'm your advisor. You're interested in immunology, neurobiology, and taking care of patients. Perfect. You're going to be an MS doctor at 79. And I looked at him, and I wasn't shy. I just said, if I don't know something, I just said, what's MS? And his next question was, are all American college students like you? And I said, I hope not. He said, me too. We agree on that. And then he told me, that's a quote. And then he said, it's multiple sclerosis. And then every 3 months I saw him, and I went to the library, and then he and I played cat and mouse for the next 20 years about MS. But look at this. We went from nothing, or I should say, Ed, It's over there. Everything in the kitchen sink, I would say. But as my wife would say, inside the forward of her book, MS for the PA, she says, you know, the most important thing you bring to the table for your MS patients, it's not what you know or what you can do. That's important. The most important thing you bring is yourself. Because a big part of what you do is you've got to educate patients on what these are. Adverse events. What's your recommendation? And by the way, what would you do if I were your wife? And by the way, how do you feel about your wife or people you love? That comes up all the time. So it's extraordinary to have gone from nothing to have interferons. And by the way, I'm going to try to pepper this with what's new. Yeah, we've had interferons, but now we have Avonex with the pen, the auto-injector. I really thought it was nice to have a convenience, easier administration, a little bit divisive, keep people on the drug. I had no idea it would be as transformational as it has been. It's making people who have been injected for years quite competently, who now don't see the needle, it's stereotype, it's made a difference. And things that help patients do what they do easier, better, because, you know, we're not those patients, we don't have to do the shots they do. It's been a real game changer. So it's amazing to think about the interferons with glutarin or acetate, and recent studies have demonstrated to us, you know, there's a lot of hand-waving about how interferons are better and faster. A number of studies have shown, you know, they're probably more similar than different. These drugs work, and they don't work, right? Depends on who you're treating. If this were EAE, experimental allergic encephalomyelitis, and we were an inbred strain, we would know what causes it and what to treat it with. But we are an outbred strain, which is why this list is going to get longer in a minute, because there's no single drug that's the right drug for any individual patient. Mitoxantrone, the chemotherapeutic agent. Can I see a show of hands? How many people in the room are still using mitoxantrone for MS? It is approved for the relapsing forms of MS, people not doing well, getting worse. There is a time to use it, but we've got to be careful because the French were wrong about this. The incidence rates of acute promyelocytic leukemia, that's the most common one, wasn't 0.25. They were off by about a log. It's about 2.5% if you follow people over time. And the two leukemias that I induced in patients, one was after the third dose of 12 milligrams per square meter, and the second one was 5 years after the fourth dose of 12 per square meter. So you have to continue to follow those patients. And by the way, ejection fractions don't stop. When you stop this drug, it's now required, even if you've had a single dose, a vacuolar cardiomyopathy from an anthracene-dione, and this one in particular for MS, can occur years later. So once you're in, you're in. And then what I'm talking about is these patients should be having annual ejection fraction estimations, either by quantitative echo or by a muggle. And then we have natalizumab, and arguably this is going to be among the most contentious in my discussion because I'm going to talk at the end about this whole issue of antibody positive against the JC virus versus negative, and how might that influence your thinking about the risk stratification of a patient sitting in front of you who's been, let's say, on the drug doing great, but now you know they're antibody positive, or they were negative and they seroconverted to positive, and what do? The first thing to do is take your pulse and don't freak out. Because when you freak out, the patient freaks out. Then they get an attack and it's your fault. You stressed them out. So you don't do that. So we'll talk about the practical pearls of what we do in those circumstances, or at least what we do in Dallas. That doesn't mean that's what you should do. Then we've had a completely novel mechanism, whereas we knew a lot about interferons, glutarin or acetate. Natalizumab is this adhesion molecule inhibitor antibody. Fingolimod really taught us something new about the way cells traffic. Because we know that fingolimod is a novel mechanism modulating the sphingosine 1-phosphate receptor. I'll show it to you in a minute. It has the ability to have a bit of a bias in sending the central immune cells, which includes the repertoire of autoimmune cells, back to the lymphoid organs, but does that less so with respect to the effector immune cell population. Not absolutely, but less so. And the reason why you care about that is because what is contained within the repertoire of the effector cell population? Response to recall antigens. Your cells against polio, measles, mumps, rubella. How many people on Gilenya have come and have had crudescent polio, measles, mumps, rubella? Nobody. And the reason why is this is not an absolute all or none redistribution. There is a parcellation between these different immune circuits. And then most recently, we've seen the approval of teriflunomide. This is the relative of leflunomide, which was used as the drug Rava in Europe, mostly for rheumatoid arthritis, but also psoriasis and psoriatic arthritis. And yes, guilty as charged, used in Dallas, Texas for MS as well, because you know and I know Aubagio is a DNA-based synthesis inhibitor. In this particular case, it's pyrimidines, principally uracil. Is that right, Erica? You mentioned mycophenolate mofetil. CellCept is the cousin of Aubagio. One is inhibiting pyrimidines, that's this one here, through the inhibition of dihydroarotate dehydrogenase. And the one you use in myasthenia, and I do too, my hand is up. You know, by the way, there are people who lie, people who don't knowingly, and there are people who lie about lying. A lot of people didn't put their hands up, but you know and I know, you know they use it, right? Right. We know. So I'm talking about CellCept. So we've used CellCept for a number of years. That's a purine DNA-based synthesis inhibitor. We know a lot about it. It inhibits adenosine monophosphate dehydrogenase. By the way, here's another creative cooking problem. Transplant guys will tell you, we know when people go into organ rejection and they're on the blockbuster CellCept, they've done great, and now we have the ability to measure CellCept levels, and guess what? We can measure enzyme inhibition effects. What do you do when you know a certain percentage of transplant patient recipients get an organ, they're on CellCept, they do great, but all of a sudden their cells are so smart, they start inducing the enzyme. Could you imagine a little yin-yang where you say, okay, I can outfox these guys. I will oscillate their DNA-based synthesis inhibition by giving you 6 to 12 months of purine inhibition, vis-a-vis CellCept, and then I might think about transitioning over to a little bit of pyrimidine. Good luck for the cells to keep up with you on that one. I'm not saying that I've done this in MS yet, but I'm in the process of doing it in somebody with a different immune-mediated disease, and I've asked my transplant colleagues, have you guys thought about doing this? Turns out some of them have done it with leflunomide and with other agents. Not this one yet, it's probably hard to get it, right? Very expensive, $40,000. This is the recent one. Do not confuse Aubagio with Bellagio, right? That's the hotel in Las Vegas, even though they might have had that meeting there. Every time, like, I love this name, every time I say it, Rich, I feel like I really want to say Aubagio. Anyway, teriflunomide. Now, I say these are the emerging therapies, but these are not emerging, they're here. Fingolimod is here. This was approved September 2010. We just had teriflunomide, but I put them on the list of emerging because they're relatively new to many of us, even those of us who are in the clinic and do this all the time. So I will say a few words about each of these. BG12, dimethylfumaric acid. This is the relative of fumaric acid, which has been used in Europe, mostly in Germany, as Fumaderm for psoriasis, psoriatic arthritis. And we're waiting on this one, Stan. I'm told that this will be approved the 26th, 27th of March, and we'll be able to write it and use it by April. It's an interesting drug because it has both anti-inflammatory, immune modulatory mechanisms, but has taught us a lot about oxidative stress mechanisms, particularly those that work through NRF2 pathways. So a very, very interesting drug. You already heard me mention CAMPAT, the CD52 deletes the immune system, you reboot, B cells come back faster than T cells. That's the one I was talking about. And then, of course, rituximab and ocrelizumab. Ocrelizumab is in trial, but it was the UCSF group that nicely showed in patients with multiple sclerosis that rituximab looks promising. We've used it for a number of years, initially in NMO, our drug of choice actually. That's the one that you could use at doses of 100 milligrams, $650 for 100 milligrams, and we'll get the CD19 down to 0 for a mean of about 100 days, whereas Erica's regimen, 375 per square meter times 4, or a gram or 4 grams, might get you through 6, 9, 12, sometimes as long as 15 months before the CD19 cells begin to come back. By the way, this is a very important curl. I'm sure you would agree with me, I would hope so, Erica, is that you can't profile patients 2 or 3 times with Rituxan infusions and say, I know you. You come back in about 6 months. So we can stop doing the labs every month and just do them twice a year. I did that, and if my mom was alive, she would say, Elliot, if I'm not in Texas, I'm in California, you must apply your own Pachentuchas for having made that assumption, because it was totally erroneous. I have patients who came back at 6 months, 6 months, 7 months. So I conservatively gave them treatments at 5 months, and they did well for a year or 2, and then all of a sudden, boom, this is NMO, 6 segments of myelitis. What happened? CD19 was at 20%. What happened? They got the drug, but you know what happened? The cells came back by 2 or 3 months. So one of the things we've learned is we've got to check every month, because once the cells begin to climb to 1 to 2%, now we're talking about B cells, we're talking about rituximab, ocrelizumab, the curve is not linear, it's sigmoidal. You go from 1 to 2% right up to 10 to 20%, and that's when my neuromyelitis optica patients will exacerbate. MS patients, not as quickly, because it's really, you can't predict, it's unpredictable, but we do the labs every month for that reason. Laquinimod, this is a Teva drug. FDA wanted some more information. This looks like it might be very interesting in terms of neuroprotection, brain atrophy. We need more studies on that drug. And you know what's interesting about cladribine? Aubagio and cladribine have something in common. Aubagio is approved. Remember, that's a pyrimidine DNA-based synthesis inhibitor, but it is a pregnancy FDA-designated X, and so is cladribine. And cladribine looked terrific in trials. There's disease-free status, no lesions, no black holes, no attacks, no progression, 44%. And in the affirm with Tisabri, 37% versus 7% in placebo. And yet, that was hung up because the concern about X-file, and we needed more data, and the company said, no mas, probably would have been another 200 million, but it probably rolled the dice for 800 to $1 billion already. So this is my editorialization. Will we see a second coming of cladribine? I don't know, because if you've got an X-file drug, pregnancy, 80% of my patients in Dallas are women, and many of them we're treating for their relapsing form of the disease. Many of them are still in the pregnancy age range. So we've got to think carefully when we spend $1 billion and say, who's going to really be the downstream recipient of this $1 billion drug development path, and will there be enough shareholder value for the companies to really develop it? I'll just let you answer that question yourself. But it's sad we don't have the ability to really use it in the way we'd like to use it, because there are many people who are not women, pregnancy, and this is a drug which has fairly impressive efficacy, as we've known from the days in San Diego with Jack Sipe and others who used this drug parenterally. What about this issue of disease-free status? This is a fiction, but I have to bring it up because it's in the literature. What we mean by disease-free status is what you measured in the clinical trials constitutes disease active or disease-free. So when we look at this, we're saying no evidence of attacks, no progression, and no radiographic measures of activity, because we measured it. But let's be very clear, disease-free activity, disease-free status, does not mean that your patient is disease-free. Isn't that right, Larry? You're not mini Larry in the tissue. You didn't do mag transfer or diffusion tensor. All you can say is by conventional imaging, no activity. All you can say by virtue of defining attacks and progression, you don't see it. And by the way, we're delighted to have it. Everybody wants to know, how am I doing and how do you know, Dr. Frohman? Well, I look at my exam, I look at their exam, which is activities of daily living. We look at their radiographic exam, and we want them to be disease-free by how we measure it. But that does not mean they are truly disease-free. But nevertheless, we do have